we're going to have to struggle with how we present these findings. I think the one thing that will help us, and I'm just going to show regression estimates for readmission because we got the MDS data so recently. We've run some stuff for some of these outcomes, but we're not sure that we've got it coded right, and so I don't want to put them up here. The result, I will say that the results we have get results that are consistent, whereas the readmission, we had that from a long time ago. We had carefully coded it, we've checked it, we've got readmission rates right. I'm just reporting readmissions here. We also have, because we didn't have the evidence, we're going to take from the MDS data and say readmissions related to events that are coded in the MDS. As maybe some more nursing sensitive readmission. But we get significant effects that lower readmission rates with better staffing, lower readmission rates when you have more RNs, sort of not quite significant, lower readmission rates when you have more LPNs. Our reference group is AIDS here. And for contract nurses, in one of the models but not in the other that I'm showing here, we get, when more of your nurses are contract nurses, you're getting more readmissions. And this fits into this team framework perspective we're taking. The contract nurses are coming in, they're not part of the team. They're a stranger to the team, so the team isn't as well integrated. And we get this consistently in our acute care results. Some of you have seen our acute care results. One of the things that struck us as we started to get these results is that the effects we're getting on staffing and tenure and these other things are about an order of magnitude smaller than what we are getting across the different outcomes in acute care. And haven't done the calculations because we don't have the final estimates here, but my rough guess is that with these very small effects, the better staffing may not pay for itself, whereas in our acute care findings, we were finding that the better staffing was actually paying for itself in terms of shorter lengths of stay and fewer complications. In terms of tenure, we're getting this mixed up finding where if we just lump the average tenure for all the employees together, it's a very small effect, but that the more readmissions in the units with more tenure. But when we break it apart, and I realized when I was on the plane that I didn't have the result with me that had that broke the tenure and had a variable for the AIDS, and unfortunately our server crashed yesterday, so I couldn't get the other result and have that there. But what this is telling us is that the tenure effect is different for different types of employees. We'll have the result that has the other plugged in there. I just don't have it yet. And because these are so preliminary, I want to emphasize that we're going to take this in a couple other directions. In terms of, we know that we've got, this is only long-term care units, but we've got different types of long-term care units. So we were controlling in the model for the patient characteristics, and one of them was the share of the patients in the month that were less than 90-day stays. So we were sort of controlling for the units. And the other thing that I should have mentioned earlier is this is all done within a fixed effects framework where we're putting in a fixed effect for each year. So that's pulling out things like the unit work environment are being captured by this fixed effect. So we're really, and the estimates are being powered off the variance within each unit compared to itself for these different characteristics. So it's a much better way to try to capture these things instead of just looking at a cross-section. And in terms of this, in our acute care analysis, we actually did the sensitivity of comparing when you do it with and without the fixed effects models, you just do a cross-sectional model, and you get much bigger effects. If you just do a cross-sectional effect in the acute care, you get a much bigger effect for nurse staffing, but it's a biased estimate. And actually we get things like the contract nurse effect reverses, statistically significant in both cases. So using this framework we have, where we're exploiting the fact that we have many, many months of data, and we can control for the unit-specific, these other unobserved characteristics and characteristics that are hard to measure, you get much more accurate estimates of what actually are the effects of changing the characteristics of your nursing staff. Implications in terms of making conclusions for this. Well, the staffing is higher and more stable. That's all I've mentioned it. That's going to do it. Yet, even in this situation with very high staffing, very stable staffing, we are finding that nursing hours and skill mix and tenure and contract nurses matter. And we think if it's mattering in this place where you actually have things the way we sort of want them, with stable nursing staff and adequate nursing staffs, it's certain, we can reasonable conjecture that it's going to matter even more when you don't have those characteristics. One of the things that we've made consistently here is that interventions that identify, if you have places where you aren't retaining your nurses, you need to retain their nurses. Our data don't say what you have to do to retain them. It identifies that it's a problem that it probably uses some more, is the focus of some organizational focus. And in terms of the site visit that we did, that unit that I mentioned, the one facility where they had the two units that were very different, the director of nursing actually put the nurse manager in the good unit, moved her over. She actually put her over both units temporarily. Get this unit straightened out, and then we'll bring in another manager. And it actually changed and got better. But it's the sort of focus of, okay, if you have turnover, you have organizationally you have a problem. And as I mentioned, we have these further refinements in the analysis underway. And the other thing I want to mention is we have strong buy-in from the VA leadership, both in long-term care and nursing, and they are going to work with us to have committed that, okay, once we have final findings, we're going to pull together a committee of managers and staff nurses from a spectrum across the VA, bring them in to meet with you to develop a set of actionable policy items to try to disseminate what we've learned out into the field. And we'll be able, what's not in the scope of this study, but once we've made those recommendations, because of the VA data systems, one can track how that would have an effect. Next.
Thank you very much. Are there any questions? Okay.
I was just having a little trouble understanding the readmissions outcome variable. Because in long-term care, that's not usually something. So is that readmissions to the hospital?
No, that's meant that you were sent back to acute care. Okay. Readmitted to acute. I'm sorry, I wasn't clear. It was readmitted to acute care from the long-term care unit.
I got it. Okay, thank you.
We need to write that as hospital admissions. And what's really nice about these VA data sets is because we're following the patient. It's just sort of like another unit. We're following a patient from the long-term care setting to the hospital and back.
So we, in a standard, some of these data sets, they might know, oh, the patient got readmitted to the hospital. We know what they were readmitted to the hospital for, and
to say hospitalization.
Yeah.
We'll clean up our language.
Yeah. We were admitted from when they were moved from a long-term care setting back to acute care. We actually have a discharge abstract linked for what that acute care admission was about.
Any other questions? Yes.
You did study this part and came out of your study in terms of the hours per care day being larger or greater in the VA long-term care system, and also that there was more tenure or continuity staff. Do you want to guess why?
From the, yeah.
I mean, as to why why do we see that? I think it's a function for the nurses that want to work in the long-term care environment. From the feedback we're getting is that they consider the VA to be a better employer. The pay is as good, if not better, depending on the, and compared to most long-term care facilities, the benefit package that the VA is providing is much better.
Well, when I went and talked with the nurses and the aides at both in acute care and in long-term care, there's very much some difference, because I'm not a VA employee. So part of it, one of the nurses in the long-term care, one of the LVNs actually was very adamant about the changeover in the other long-term cares with change of ownership. So, I mean, this was very difficult for her. And she said, I've worked other long-term cares. I've been in long-term care for a long time. These other facilities, you know, they're changing ownership, and here, so that was one for her. But there's something else, I think, in the VA, which is this organizational commitment. And you either, I think, if you stay there, you know, and you like it, these people are there to care for our vets. And they know that, and they talk about it. And there's this relationship, you know, that's very strong. And so I think that sort of the tenure is naturally stronger, and they want to stay with people that they care about, especially in the long-term care setting.
Another thing that may be influencing the VAs, the VA really pushes developing their nurses in-house. So there are lots of people in the VA who didn't have the wherewithal to go out and get a bachelor's of nursing straight away, went in, started as an aide, used the educational benefit, got their LVN, got their A nursing degree, got their bachelor's nursing degree even. You know, and there's people that progress up the system like that. And a lot of the VA's nurses actually, and this is, I would say almost half of the LVNs that I talked to in 2 site visits actually started as aides and then got an LVN and under the education benefit. And so they'd been there, been at the VA longer than they'd been at the VA as an LVN.
So I know we got to go, but what about...
Well, so in view of that, I wonder
What accounts for bouncing around of staffing over the year then?
The variation in staffing?
Yeah. Is that vacations?
No. The staffing levels per, you know, you have some fluctuation in staffing.
And that's what you're
you know, hours per patient day. A lot of that is really driven by a number of patients that are there.
And sick time.
Why would it
floating?
Why would it be driven by the number of patients?
Well, in the short stay units.
So it's really the patient load that's bouncing around, not the staffing.
There is some bouncing around of the staffing too, because I mean, having looked through these data month by unit.
You're there when there aren't very many patients, you're less likely to go to the inpatient, to the hospital. I'm not sure who we give. I guess we give credit to nurses either way, but it's a little different story.
But it's all. I mean, there also was clearly variation in workload. You know, workload trends up over time, and they adjust their staff.
You know what I'm worried about endogeneity of that variation.
Yeah.
And one of the things I'd like to just leave you with is that we've just been talking about how different the VA is, and so why this isn't generalizable. But what strikes me is in this stable environment, we're still getting these effects. And so that, you know, where it's likely to be more, we'd likely to see larger effects in an unstable environment. So, you know, that's one of the points that I'd like to leave you on.
Some of the, a quick question, we're pretty much at that, but some of these effects that you're showing are very small. They may, it sounds like some of them may be borderline statistically significant, but they're still very small. Are there other quality, did I hear you say that you're looking at other quality parameters too?
We have looked at, you know, we've looked at the other, you know, the quality indicators that you can get from the MDS, you know, the falls, the pressure ulcers, and so on. And those effects are a little bit bigger, but they're still reasonably, I mean, we were looking at monthly rates of them, and so it was small. We're going to aggregate them on up, but the effects are pretty moderate at the staffing levels we're observing.
So some of the differences you see in some of the other indicators look like they may be more pronounced than readmissions.
Yes.
All right.
And then the next, obviously, it's one of the things we're funded to do is look at efficiency to sort of say, you know, if we don't have somebody going back into a hospital, and what is the sort of put a cost issue on it, and we'll look at that,
Okay.
even though they're small.
All right, thank you very much.